Hello and welcome to Chapter 7. This is Part 8 of our lecture series here. And we're going to continue on with special considerations for the pediatric patient. And it's going to kind of jump around a little bit, but I'll bring it back all together at the end. So you cannot just look at pediatric patients as little people because they're not. They have specific differences in their metabolism and their body structures and the way they process medications that are much different than the adult. Sometimes children may require a relatively higher dose. That doesn't mean it's a higher dose, but relatively it may be higher and more frequent administrations. Because sometimes their metabolism may, things may be sped up because they have a higher metabolism. Their excretion rates may be higher. And in some things, actually, it may be slower, so sometimes they may need lower dosages. So we don't want to just assume that we can just half the adult dose and be okay, because that's not true. And it says here, products of metabolism can vary, which sometimes result in unexpected responses in the pediatric population. The problem is with pediatric patients is that we do not do a lot of clinical trials on pediatric patients. Because like I've said in our earlier lectures, parents just are not lining up at the door to let scientists experiment with their children. So geriatric patients are kind of similar. Things start to change in their life. Their metabolisms begin to slow down. Their ability to excrete can slow down. Their gastric motility can slow down, liver functions can slow down, and this can cause absorptions and eliminations to be delayed, which means that sometimes we want to expand the normal intervals of how we give medications. Also, geriatric patients a lot of times are on multiple medications. I don't know if you've ever gone out on a geriatric patient and they bring you 2 grocery bags full of medications. That's a lot of medicine to take on a daily basis. And these interactions can cause medications not to function the way that we intend them to, or it may cause them to not function at all. So next I want to get into our scope of practice. Scope of practice is an AMT. Gives you the authority and the ability to administer medications. However, you are legally, morally, and ethically responsible for every drug you administer. If someone hands you a drug and says, give this, if you gave that drug, you are responsible for what was in it and how much was given. So before you push a drug into a person, you need to make sure you know what that drug is and what the proper dose is supposed to be, and make sure that the proper dose is in that syringe or in the or however you're giving the medication. If it's in pill form, you want to make sure it's the proper dose, that it's given in the proper route at the proper time, that it's the right medication, the right patient, and so on. So you might also want to know what drugs interact with the medications you may administer, because there's not many drugs that you're going to administer as an AEMT that you have to worry about, but one of them could be activated charcoal. So the way that you would find out how that drug's going to interact with it is you would call poison control, or you would look it up in a physician's desk reference, PDR, or you could use Hippocrates or some type of drug reference. But if you're ever in doubt, you should contact medical control. So I want to talk briefly here about fluids and electrolytes. Fluids and electrolytes are pretty much what most of us are made of, and they are essential to life. The drug, what we mainly deal with in the pre-hospital setting is going to be crystalloids. That's our normal saline and lactated ringers. And depending on what service you work for or what your service's preference are, you may have one or both. But crystalloid solutions can come in different concentrations. You can have an isotonic, which is equal, pretty much balanced to the same thing as the human body. You can have a hypertonic, which means it has more electrolytes, or you can have hypotonic, which means less. So if you can remember back in the day, maybe later on in this program, we'll talk about diffusion, and hypertonic solutions and hypotonic solutions can cause shifts in fluids, and sometimes you want to use them for certain situations and not for others. And you may also be called to administer colloid solutions. More than likely, I do not see colloids being used in the field, but you could see them on a transfer. And these are protein based, so they are not typically carried on the ambulance. I know in my entire career I've never seen one on an ambulance, only on transfers. And we'll get more in depth next chapter about fluids, what fluids to use, and what types and in what situations to use them in. So, all right, well, that concludes this section. Our next section that we'll be going over, we'll talk about factors altering drug responses. So, as always, if you have any questions, please make sure you contact me, and we'll see you on the next section.